Hi, everybody. I'd like to welcome you to our April event for the Pediatric Stroke and Brain Injury Education series. We're very excited and lucky to have Claudia and Alex Newton here, as well as Dr. Ichord from Children's Hospital of Philadelphia to share today's session. I'm going to share a few intro slides about the series and then hand it over to Claudia. Okay, so our topic for today is Journeys After Pediatric Stroke, a neurologist's perspective. And I just want to introduce myself and the series. I'm Mara Yale. I coordinate this educational series with a team, and the team is growing. It started at Mass General Hospital for Children, but it's really a Pediatric Stroke Advisory Council, and we've broadened it to include pediatric stroke and brain injury education, because much of what we teach in terms of rehabilitation after early brain injury really doesn't matter what kind of brain injury it was, whether it started with a stroke or something else. And we have many partners now presenting talks. We've started from the Boston area, and Spalding Rehab Hospital I'll mention, because this playground here and facility is the site for one of our in-person events coming up May 21st. And just to make a disclaimer, this is for educational purposes. If you want medical care, obviously you need to seek your nearest medical team. So please take advisement that this is educational. Sorry. So just to give you a little history on this education series, we started in 2019 with a couple of in-person events. And we sadly had to stop the in-person events as most things stopped in person in early 2020. But we're excited to be going back to in-person. And in the meantime, we've built quite a robust series of monthly webinars, all of which are now up to date on our YouTube channel. So we had 2 events in person in Boston in 2019. In the 2020-2021 season, we had 10 events online. And this year we're on track for 9 events online, and then Reconnecting in person, as I mentioned, May 21st. These links I'll put in the chat as the talks start. And just want to invite you to May 2022. Our theme is to reconnect. All of us are craving reconnection after the past 2 years of isolation. And we have 3 exciting events planned. We have 4 young adults who are participating in a panel discussion on May 4th. Then we have an occupational therapist and a physical therapist teaching how to play to thrive. And we'll all be reconnecting in person on the Boston waterfront outside with activities to do for anyone who's in the greater Boston or New England region who's welcome to come. So at this point, I'm going to stop sharing and pass it off to Claudia Newton, who's on our team of the Advisory Council, to tell her story and her family's story.
Good morning, everyone. My name is Claudia Newton. I'm with my son, Alex. We are actually in an empty room because we've just moved to Montreal about 2 months ago, which is exciting. My husband's job changed, so we'll be here for a few years, but so big changes. So I am and have been in EMS for 20 years. And 10 years ago, on a snowstorm, as a day off from school, which I like to call it the snowstorm that may have saved my child's life, Alex was home and complained of tingling in his face and body even trained in EMS, I assumed he pulled, a nerve. He was doing karate at the time. I thought he was watching cartoons because it was a snow day, and I assumed, get up and move around, you're fine. A little later, he complained about tingling in his leg. Again, let's go. We went outside in the igloo, went for a long walk. Later in the day, he talked about just one-sided tingling. And that's when, without thinking anything of it, I did give him a stroke test. I don't know why, but I was thinking something neurological, and to my complete shock and horror, when he raised his arms in front of him, as many of you have had older children when they are in the midst of a stroke, one of his arms drifted, threw him in the car without even calling the ambulance, and drove through about 6 feet of snow to our local hospital, brought him into the MRI, and as many of us know, that fear, that instinct kicked in, and I knew something was wrong. The doctor walked out and unfortunately did say, "We did find something. Your 10-year-old has suffered a stroke." To which, even in EMS, I was shocked and frightened. Can't lie, still am frightened to this day. And ended up going into the ICU at Yale. We've since been to Columbia. We've worked with Children's Hospital of Philadelphia, where Dr. Ichord is from, and now we're with Mass General, because we realized Alex had had not one stroke at that time, but had that stroke we found was probably his 3rd or 4th. And he subsequently, 10 months later, even on an aspirin, had another stroke 4 times larger than the one previously, which came with more traditional stroke symptoms with facial droop, severe headache. And he then went on Coumadin as well. So it affected us obviously quite dramatically. Alex, his worst symptoms became migraine. Physically, luckily, Alex did not have any disabilities or challenges, except for migraines that, as he will tell you, kept him in bed for about 4 years, and unable to be in high school. And I will say the way it affected our family, I wish I could say that we all banded together and rose together to make Alex to come together in such a frightening moment. We didn't. Our family's still intact, but it took a massive toll emotionally on our family dynamics. I would say moving forward, if I'd known then what I know now, obviously I would have been less fearful. If you had asked me then, would I be sitting next to a 21-year-old, young man in college, I probably would have said no. I would not have believed it. There is hope. It's not a sprint. It's not even a walk. I wouldn't say it's even a crawl. It is moment to moment when you have a child, whether your child is actively in crisis or on a day-to-day basis, it's a completely different mindset as someone who loves a child with stroke. We then turned to Dr. Ichord for stroke, which thank goodness we'd found her, and then turned to Mass General for migraine management. But it's not easy. It's frightening. But I'm here to share personally that there's a tremendous amount of hope and science and support through things like this workshop that can get us as caregivers to give children our support and love in a way that is the most productive. Knowledge is power. Knowledge is power. So I'd love to turn it over to my son, Alex, to tell you his perspective.
Hi everyone, I'm Alex. I hope that you're all doing well. I'm happy to say, despite how horrifying the story seems and is, I'm doing very well today, but back then I was doing just absolutely horribly. As my mom was saying, I just could not get out of bed. These migraines that I presented with were horrible. I was vomiting. I could not get out of bed. And the worst part was, I think about once every month, they would present just fakely as strokes. So we would have to rush to the hospital, get an MRI, and be told it's not a stroke, thank God. But it was very frustrating to, after the strokes, be or still have something that just would not improve. And for a very long time, we couldn't figure out what exactly the condition was. And it's something called POTS, which I didn't understand. We didn't understand that it's a blood pressure condition. And I had a lot of ineffective treatments that made it worse, treatments that kept me in bed. But finally, once I received the correct diagnosis, I improved, but not immediately. I had to learn a lot of lessons along the recovery journey. And a lot of those were, I had to force myself to do things I didn't want to. I had to discipline myself to get out of bed, go to school, go do sports, work out, eat healthily. It was just the routine to become better. It wasn't just relying on medication to be in a better state. Forcing those healthy habits was so important. Additionally, something that was really helpful too was remaining open to other treatments. The most helpful thing to my migraines now is an electrode I put on my forehead, which stimulates my vagus nerve called cephaly. And when I heard about it, I thought, that's not going to be helpful. But now it's the most important thing to my migraines. Additionally, I have an emergency medication which I take, which is Valium. And when my doctor said this may be helpful, I thought, there's no way I'm going to take Valium for migraine. I don't want to take that. But once I did take it, it helps so much. It just relaxes my muscles and I feel great. And because of the fruits of my effort and trying to constantly improve and keeping this constant routine, I just feel great. I'm a senior in college now. I'm at Villanova. If you watch the NCAA, you know that we didn't do so great and we're not the happiest, but I'm having a great time at school. And this past summer, I actually had the opportunity to work for the series, and it was so great to work as a survivor of stroke, helping other survivors of stroke. It was a great experience. And this summer, I'll actually be working in Montreal at an agency. So I'm going to hand it back to my mom.
I think our story, with the thing that I think Alex and I would both like to emphasize is the empathy toward what unfortunately is a club none of us want to be in, but we are all in, of loved ones who care for children that have stroke. There's unfortunately very little support compared to other pediatric diseases or illnesses. I've been involved and inspired to try to help fundraise for pediatric research for stroke specifically, and also for this workshop series. There is going to be a link on the page to donate. Anything from $1 up would make a world of difference to keep this kind of workshop doable. If there were something like this back when Alex first had his stroke, I would have been incredibly grateful. There was just very little in terms of support, and parents and loved ones coming together to ask questions, to be curious, to learn. So I am so grateful for MGH, for Dr. Ichord, who I'd like to introduce, who is the director of the Pediatric Stroke Program at Children's Hospital of Philadelphia, who is such a critical part of Alex's journey to get better.
We love her.
We love her. And she has been in this for so long. She is, as described by her colleagues, she is the tribe elder of pediatric research and care, and cannot say enough wonderful things about how she's held our hands and made this moment by moment journey hopeful. So thank you for listening. I also have done some fundraisings, so I'm going to put my email into the chat. If anyone's interested in doing any kind of fundraising for pediatric stroke, whether it's a lemonade stand to anything bigger, I'd be so happy to talk to you about the fundraising that I've done and work with you. So thank you for listening. I'd like to introduce the wonderful Dr. Rebecca Ichord. Thank you.
It's a great honor and a great pleasure to be part of this wonderful community that you all have built. And I feel as though my connection to your personal journey has given me as much as I have given to you or to the community. I can speak to the fact that Claudia and Alex are an inspiration and have always been an inspiration to me. Specifically in regards to the resilience and determination that Alex has shown in overcoming, and not just living with, but overcoming the many medical challenges. This is something that I see over and over again in children and families. We don't in medicine know how this kind of energy, this kind of resilience comes to be. It just happens. And if it weren't for the strength of the families and the determination and resilience of the patients, I think our abilities as physicians would be much less. So it's being in these kinds of long-term relationships and seeing how children and families rise to the occasion and to the challenge. And even after years of struggle and years of dealing with symptoms, you have in front of you someone as a great source of pride as Alex is. It makes me quite emotional to see you. So I appreciate that very much. So without further ado, I'm going to talk now what the perspective is from the neurologist who has been a part of many journeys of many patients and families. I'm going to try and impart some knowledge about where we are today, where we came from, and understanding pediatric.
It's okay.
If anyone has questions, we'll have a discussion period at the end, or you can type them into the chat. I may not see them at the moment you type them, but I'll certainly come back to them at the end of the conversation. So I'm going to share my screen. Can you all see my screen?
Yes, we can see it.
Great. So I changed the title just slightly to say that this is about journeys toward recovery after stroke, a neurologist perspective. Okay, how is this? Okay, so I'm going to start with another young boy's journey. This young man had a stroke. He was previously healthy and enjoying life and doing everything that a healthy teenage boy should be doing. And then one day, 16-year-old, he had the onset after a relatively low-grade football workout where he had no particular injury. He suddenly became dizzy, had a headache and trouble with vision and slurred speech. This happened kind of late in the day after the practice had already concluded. And he was taken to the local emergency room where the team there examined him and performed a head CT scan, which was normal. And they interpreted his picture to be most consistent with a diagnosis of migraine. This story may ring some bells for others of you who have been through a similar journey. And here is his head CT scan. And this is just one slice of that CT scan, but from all intents and purposes, in fact, it was normal. And this is one of the pitfalls that happens frequently, where the diagnosis of a stroke relies on having the most sensitive kind of imaging. And it also points out that the symptoms that a patient starts with can resemble those of many other relatively minor illnesses in children. So he went home and he was seen by his primary care doctor, who, because he was still having headache and dizziness, and exam to the pediatrician seemed to be normal. The pediatrician was concerned enough to phone a friend, basically, someone who had some neurological expertise, and described the story. And they thought it was some kind of viral process that affected his balance system. And so he was given some supportive medications and sent home. And the story didn't end there. His headache improved gradually over a few days, but then about day 5, he had a worsening and his headache got much more severe. He got up to take a shower and collapsed with a new sudden paralysis of the left side of his body. So this was an unexpected turn and quite worrisome. He was again taken to the local emergency room, where he arrived within about 30 minutes. And his exam, in fact, did show a complete loss of strength and sensation of the face, arm, and leg. And he also had slurred speech. And I put these other symptoms up here about vision and speech, because these are some of the clues that a neurologist would want to know about to help us understand where the part of the brain is that's affected, and help us to think more specifically about what could have caused it, and whether one should worry about a stroke. And so he again had a head CT scan, and I've pointed the arrow here to show you that there is this abnormality in a part of the brain called the cerebellum. And this would have been the abnormality that came about as a result of the very first set of symptoms he had. This location does not explain his new set of symptoms. So anyone with neurological training would recognize that this head CT only tells us part of the story, and that it's really necessary at this point to get more definitive imaging, and to think now clearly we're probably dealing with a stroke syndrome, and he needs to have a complete stroke risk factor evaluation. So the next thing that happened, he was transferred to our center, where we have in place specific systematic protocols for emergency treatment and evaluation. One of the things that many people who are aware of stroke care might think about is whether or not he might have qualified for what we call revascularization or hyperacute therapy, with either medication to dissolve the clot or with a procedure to remove the clot. And unfortunately, he was outside that time window for such a therapy. So he arrived to us, and at that point he was sitting up and had some IV fluids running. And the reason I make this mention about what we do as part of our stroke care is just a very simple putting the head of the bed flat, and we could see immediately that his symptoms improved. And this is part of the simple protocol that we use in acute care. And I'll come back to that kind of protocol that we use in the acute setting. And so as neurologists, again, we're thinking about what his symptoms are, and they seem to point out that 2 different events occurred, and that probably 2 different locations and 2 different vascular locations were involved. And so he went ahead and had the imaging, and you can see in this lower left panel, this area of abnormality in the right side of the brain, which corresponds to his left-sided paralysis, as well as we can also see in the cerebellum the previous event that he had. And when we do this imaging, we absolutely want to see what the vessels look like. And you can see in this lower right panel, we can see his arteries actually look quite open and pretty fine. So this helps us narrow down the potential mechanism. And as we narrow that down, we know, number one, it is a stroke, because these are lesions that conform to vascular territories, and that the blood vessels look healthy. So this is more likely coming from a clot that arose from the heart. And in fact, that was our next step. He got an echocardiogram performed, which in fact did show that he had a clot inside the heart, and that was the source of his clots that went to the brain. He was treated with anticoagulation therapy, and we followed up that study a few days later to see that the rest of the clot had resolved. I can't go into all the other detail, but we looked high and low for why a clot might develop, for why there might have happened in the heart, and couldn't find any other source of either a clotting disorder or a cardiac abnormality. He did go to inpatient rehabilitation, and sort of fast forward, by a year later, he had improved very significantly, but was left with some degree of left-sided hemiparesis. Now, I wanted to say also, just as you heard in Alex's story, there is a silver lining that after his journey of acute stroke and rehabilitation and coping with those effect of that, those deficits on his life, he was undaunted. And in fact, he somehow found a way to be inspired by his own challenges and his own travails, and went on to graduate with honors from high school, and was inspired to go on to college to study biomedical engineering with the goal of becoming a leader in improving and developing new rehabilitation technologies for children and perhaps adults who are recovering from stroke. So this is, again, a journey that some of you may recognize some elements that you have gone through yourself, or that you know people who've gone through this. And this is what it looks like from the point of view of a neurologist. Symptoms start, they take time to be recognized, they take a lot of work to get the right diagnostic testing to arrive at what we hope is the right treatment, and ultimately we as providers accompany and promote and help this family and patient through their journey to recovery. So as you can see from this case, and many of you also, there are many difficulties in arriving at the right recognition. So people have to, number one, think about the possibility that a stroke has occurred. And many patients who have similar symptoms, in fact, the majority who have similar symptoms, turn out to have something other than a stroke. And the only way to be sure about the diagnosis is to obtain a brain MRI. A head CT scan is insensitive, especially early in the first hours. And there are many other conditions that would which mimic the stroke that would have to be identified with MRI. And these are things like infections, tumors, even migraine turns out to be the answer in many cases, but we don't know that until we've done the testing. In some cases, children are too young to articulate symptoms. Those of you who are parents of children who had their stroke at birth know this better than anyone. And then finally, adult caregivers assume it's anything but a stroke. How is it possible that a child can have a stroke? And so there's this notion in the lay public and even among healthcare providers that children don't have a stroke. And so as a result of these many challenges and barriers, there's usually a delay to the time of diagnosis. And some studies have been done to show that parents are the best detectors. Parents and primary caregivers are the best detectors. And I've learned early on that if a parent is worried their child is having a stroke, then I better take that seriously, because more likely than not, they're right. And they can pick these symptoms up within the first 3 to 6 hours. But again, because of the many delays and challenges, many children don't get a confirmed diagnosis until 24 hours or later. So I was asked to think about what parents want to know, and I don't presume to be in your shoes, but I've certainly heard you ask these questions many times. So I'll try to imagine what you might want to know from my knowledge point of view. And so I've kind of listed out these set of questions which we'll cover during the talk. So the first question might be, well, what are the signs and symptoms, and what are the common patterns, and what are the symptoms that might lead us in the wrong direction? So I want to take this back to basics. So first of all, one might ask, well, what is an arterial ischemic stroke? How do we know it has happened, and how is it defined? And from the neurologist point of view, it is a very specific and fairly straightforward definition. And that is, it's an acute, meaning it happens out of the blue suddenly, a neurologic syndrome. So it has a constellation of signs and symptoms, and that those signs and symptoms fit into a pattern that conforms to a particular anatomical profile. that goes with a deficit in an arterial vascular territory. And we can't confirm the diagnosis until we have imaging, which actually shows that there is an infarct that corresponds to that deficit. So then the next question was, well, what is a focal deficit that corresponds to a vascular territory? And this is the kind of Sherlockian, if you will, thinking that a neurologist would go through. And so we have to have in mind knowledge of the anatomy of the brain and the arteries. And this shows that anatomy in a simple cartoon. And most people know from common knowledge that we have two main arteries in the front of our neck, the common carotid artery, and then this goes up through the skull, and it branches out to supply most of the parts of the brain that control movement and thought and speech. And then we have these two arteries that come up through the back of the neck called the vertebral arteries. And then they supply parts of the brain that control balance and other life centers. So a clot or a blockage of any one of these arteries would generally produce a set of symptoms that's recognizable in an anatomical pattern. And we like to divide them into that anterior or the carotid circulation. And if you'll kind of bear with me a little bit and imagine what a neurologist thinks about. And if you look at this upper right panel, you can see that the brain anatomy is very predictable, and that the areas of the brain that control parts of the body are pretty predictable, and they correlate with vascular territory. So out over this main large part of the brain supplied by the middle cerebral artery is the motor and sensory processing of the face, which represents a big part of that territory, the arm and the hand. And then smaller areas are involved in controlling the leg. Likewise, there is control of speech, and speech generally locally is located in the dominant hemisphere, and that's going to be the left hemisphere in most people, the right hemisphere in a small subset of people. So as a neurologist, I'm going to ask myself whether the symptoms really correlate to these locations. I'm going to look for a one-sided or unilateral set of loss of both motor and sensory. In some cases, it's just motor or just sensory, but they're usually combined. And we're going to have more involvement of the face and the arm and less so of the legs. So we're going to look at face, arm, and leg. And then we're going to look for these other cortical deficits that involve the vision and language. And when we add all of these up, we can generally determine in pretty short order whether the location of the deficit corresponds with this middle cerebral artery territory or somewhere else. And then what about the posterior circulation? So these are the vertebral arteries that come up and supply the back part of the brain, the cerebellum, which is involved in balance. And this was what was involved in that young man that I mentioned, where he had slurring of his speech and loss of balance and felt very dizzy. So symptoms that are predominantly of that type, dizziness, unsteady gait, and particularly if it seems to affect one side of the body more than others, then that would point me or a vascular neurologist in this direction of the posterior circulation. And the asterisk here, or the sort of misdirect, is that it's very common for children who have their first onset of stroke to have headache, and that headache can seem all the world to be just like a migraine, and particularly when it's involving the cerebellum and the posterior circulation. This can be the most pronounced symptom: headache, nausea, vomiting, and sleepiness. And these types of symptoms are part of a dozen or more different neurological syndromes that can lead people in a different direction. So once one goes through that journey and the correct diagnosis is made, then the next question that almost everyone wants to know is, well, what caused the stroke? And a parent wants to know that, but also the treating team wants to know that, because if we don't have a good idea what caused the stroke, then it's hard to come up with the most appropriate treatment. So what causes stroke in children? And I get asked this question all the time when I meet with, whether it's a layperson or a healthcare provider. The kind of next question on their mind is, well, how is it that a child can have a stroke? And it's not really quite the same as it is in adults. So I like to think of the process of how and why a stroke occurs, not just a disease, or a disease that causes it, but it's a process. It's a journey that the brain and the arteries and the clotting system go through. And it's helpful to think about the fact that children can be considered to be one of a group that is at risk of having a stroke. And then some kind of inciting event comes along to actually trigger the stroke. And what we've learned in many studies is that about half of children who have a stroke were previously perfectly healthy. And we heard about that situation with Alex, and we heard about it in that other patient that I talked about. And the other half who are at risk are children who have a variety of conditions that we can understand and know about. So children with heart disease, being a neonate in itself isn't being at risk. You don't have to have any particular disease, you just have to be on the verge of being born or having just been born. There are children who have something wrong with their blood vessels. They may not know that they have a disease of their blood vessels until they've had their stroke. There are children who have chronic conditions such as sickle cell anemia or other cancers or things of that nature, chronic illnesses that make them at risk. And then something happens. A vascular trauma might happen. Birth itself is a inciting event, some kind of infection. And we're learning a lot about how infection might affect the blood vessels of the brain, or might trigger some kind of immune response, which promotes a clot to form. Children who have chronic disease like heart disease have to go through procedures like heart surgery. So all of these different inciting events then actually precipitate the stroke when it occurs. And once the stroke occurs, then there is a whole series, a whole cascade of events that happens where the brain circulation adapts in a way that usually is helpful, but is this adaptation or this response to the actual clot unfolds over a period of hours and sometimes even days. And so this is a nice way to think about the fact that we have this critical window of time in the first hours and days to help promote some good reperfusion and some healthy adaptation on the part of the brain and the blood vessels. And then as the brain and the child respond, there is some degree of injury in those parts of the brain that were affected. But there's also reaction to injury, and then there's recovery. And these changes in the neural networks, these changes in the functional allocation of function in the brain is a mixture of good things and not so good things. And then we do our very best to promote rehabilitation, and we put in place active rehab therapies. We make conditions as optimal as possible for things like nutrition, sleep. We manage headaches and seizures in a way that allows the child to participate in rehabilitation. And I want to kind of make a strong point that rehabilitation is much more than just therapy. Rehabilitation is getting back to living and doing and being a child in their family, in their school. So everything that we think about in the post-discharge era is really oriented to getting that child's life back on track and having them use their skills to try and recover. So what are some of these conditions and how do we go about diagnosing them? And I like to think of it in as simple a way as possible. So a stroke can happen because something is wrong with the blood vessels. because something is wrong with the heart or the blood vessels in the chest, or something is wrong with the coagulation system. And sometimes it's a combination of these things. And so how do we find these out? Well, there are certainly lots of tests that we can do where we can actually know when something is wrong. But unfortunately, there also are situations where something must have gone wrong, but we don't have a test that can identify it, or the tests that we have don't give us the answer. And so it becomes, in that situation, then we have a child whose stroke where we don't know the cause of that child's stroke. And in that situation, we call it cryptogenic. And so over time, we've learned by studying many groups of patients that about, as I said, about a half of children were previously healthy and don't have a chronic disease. Those that have a known condition, about a third have some sort of heart condition, and about a third to 40% have something wrong with their arteries. And then maybe 10 to 20% have something wrong with their blood system. But yet, at the end of the day, about a quarter of all children, even after fully being investigated, we don't know what the cause was. And so that can be both frustrating and, in a way, it can be good news. Knowing that all these other systems seem to be healthy can be and often is presented as a reassuring situation. Now, for children who've had their stroke around the time of birth, most of the time we can't identify the specific moment when that clot happened. There's usually not anything wrong with the arteries. There's usually not anything wrong with the heart or the aorta. And the neonatal stroke occurs just because of the risk that is going with being a newborn and being born. So some of these specific conditions, I'll just kind of run through a few of them, things that affect the heart and the aorta. You can have disease of the heart that's you're born with. You can acquire heart disease due to infection. You can have a clot occur around the time of an indicated procedure, or in critical illness, you might need to be on some sort of device, like a ventricular assist device, and things of that nature. What about the blood vessels? I mentioned this may be found to be the cause in as many as 40% of children, especially those that were previously healthy. And there are inflammatory conditions, and I think we've learned a lot from our research in the last 5 to 10 years that certain kinds of viruses can trigger a reaction in the arteries, and this is a transient inflammatory condition in the arteries in the brain. There are children who develop a minor traumatic injury to the arteries in the neck, which might be minor except for the fact that it then can cause a clot to form in that injured artery, and then it goes to the brain. Then there's a particular type of artery disorder called moyamoya, which is a Japanese term for puff of smoke, where there is some progressive narrowing and finally blockage of the two carotid arteries. There are a number of genetic syndromes, and this is near and dear to the Mass General group, where we're trying to better understand what the genetic basis is for some of these arterial disorders. And this is really, we're in our infancy in the field trying to understand the genetic contributions to these kinds of things happening. Then there are children who have had a tumor who have to have irradiation during their life that may cause a later stroke. And then there are coagulation disorders, some of them again being genetic, so highlighting the fact that we need to keep looking and understanding and get better at identifying genetic conditions that can make a child have a clot. Then there are acquired disorders that are caused by immune disorders. Sickle cell anemia is still a cause of stroke, although we've made lots of progress with primary prevention. And then there are children that have to receive certain treatments for conditions like cancer, or who have chronic disease of the heart or kidney or liver, which cause them to be clotters. So these are the kinds of conditions that our various stroke protocols tend to go through to understand the causes of stroke. So then the next question that usually comes up is, well, what is the best treatment and how do I use that information from my diagnostic odyssey to manage my patient or take care of my child? And you can think of it as a time continuum. There's critical treatment opportunities and challenges that happen in the first day. Then we shift our treatments to be oriented somewhat differently in the first week. And then we continue our treatment during the first year and beyond. And so what are those treatment approaches? And I like to think of the treatment as having a necessary team approach. And we need many providers and many people with subspecialties to be aware of stroke and to participate as a team member. But we also need to apply different skills and different knowledge over different periods of time. So we need a different set of knowledge and treatments in the very beginning. We need community awareness, early referral, and certainly Claudia has been on that front line. We need then a different set of skills and knowledge in the emergency room, and people who work there need to be aware of that and need to know how to do the basics of recognizing an early treatment. Then we need our kind of concentrated subspecialists in vascular neurology, neuroradiology, intensive care, cardiology, really in the intensive care units, so that we can make the earliest possible comprehensive diagnosis and put in place the right treatments. And then the work really starts from the first week all the way through to getting back to home and growing up and being part of your school and your community again. And this is where I've experienced the most, I would say, gratification, to see the hope and the recovery and the resilience of children and families as they make this journey to their life, to re-experience their life again and to be part of home and school. And I'm so lucky to be at a place that has supported having a team that includes everyone that's needed: physical medicine, rehabilitation, our social worker, my nurse, education specialist, neuropsychologist. And there's really no substitute for having a team of people, all of whom are equally dedicated, and each of us educates the other. I would be a pretty impoverished provider if I had to do all of this by myself. And it's only because I have a team of therapists and other specialists who really educate me about the needs of that child and family and how we can garner all of the resources necessary, whether it's an inpatient rehab course, or it's outpatient therapy, or it's school-based therapy, but it's also helping the family to cope with being both a parent and a provider. So, and I have never really understood how much strength it takes and how much courage it takes for parents to carry these roles and to wear so many hats. So happily, over the many years of being in this field, I've been able to see how we've grown in our ability to come up with better tools. We have an acute stroke scale that we can use to quickly assess the severity and the type of symptoms. We've been better able to understand the different subtypes of stroke and why the strokes occur, and using that information to do research and to manage individual patients. We've learned more about how to image and classify what's wrong with arteries, and we have ways of grading the severity of those arterial disorders so that we can put in place some treatments and measure whether our treatments work. We have decent outcome measures, and there's always more advances going on in imaging. So how do we do the treatment? And this goes back to that model that I presented early on about thinking about how a stroke occurs and the process that happens. So in the very beginning, we want to do everything possible to restore and maintain circulation through the blockages that might have occurred. We also want to limit the progression of that stroke and preserve the function that's already present and help the recovery of the functional areas that have been impacted. We want to get rehabilitation going as quickly and as comprehensively as possible, and then we want to prevent recurrence. So this is the kind of the thought process, and each step of this way has, in a practical way, has an order set. So we have order sets in our stroke protocols that address each and every one of these. And we have roles where each member of the team knows their role to play in working through this treatment model. So what is on the horizon, and what hope do we have for making things better for children in the future? And many of you have probably heard of this, the next big thing in acute stroke care, and this has really made a huge difference in adult stroke care. And I'm using the term acute endovascular treatment. This is just another way of saying that there are devices and procedures that can be used to go in and actually remove the clot that is blocking the artery. And this has been studied very rigorously in adults, and we in pediatrics have modeled our use of this therapy after the models and the protocols that are put in place for adults. So how does one do it, and what are the opportunities? So at the moment, the most secure or the most well-defined opportunities are defined by a time window up to 6 hours, and perhaps in some select cases after 24 hours after the initial symptoms occur. The devices are really only able to be used in children of a certain size. We hope that the device manufacturers are working on devices that can be used in younger children, and that hopefully will come along in the near future. And we have to see on imaging that there is a blockage that we can actually go after. And we have to have some reasonable idea that there is still some tissue that is viable, that can be preserved or restored. And so we measure this on the basis of the size of the deficit, and that's where our stroke scale score comes in. Now, there's certainly limitations and unknowns. So in pediatrics, it's harder to know how to measure whether there is and how much viable tissue there is still that can be preserved. It takes a lot of capability. It takes computer software that's highly specialized and quite expensive. It takes highly specialized technology with devices, and it takes a whole team of personnel. It takes about a dozen people, plus the support staff, such as nursing and pharmacy. So it takes almost an army of people to pull off this kind of treatment. We also need to better understand whether we can use in parallel the clot lysis drugs, and there are certainly situations where that can be done, but learning when is the safest time and the most effective time to combine these treatments remains somewhat open. And as I mentioned, that takes an army, and this army people needs to know how to work together as under a ticking clock. And so these are areas that are being intensively researched, and there are a couple of clinical trials that are under review. There's some in the US, and there's some in Europe and elsewhere. So again, I want to emphasize that we're not just stuck treading water. We as a community of providers are really aggressively trying to move forward and bringing the technology that's saved so many adults down to the pediatric age range. We are motivating our hospitals and our teams to come together and work in these specialized groups to bring this therapy to children and really make a big difference. And hopefully in the future that this will be helpful for more children than in the past. So the next sorts of questions are, well, what does the future hold? How do I know what my child's outcome might be, and what can I be doing, and what should we as a team of providers be doing to make that future the brightest possible? So I've certainly learned a lot about what the outcomes actually look like after childhood stroke, and one of the reasons I find this area so gratifying is that children actually, as many of you have seen, do make remarkable recoveries. There is certainly the unfortunate situation where occasionally children will die from their disease. But the good news is that the mortality is very, very low, and the vast, vast majority of children, 95% or more, survive their having had their stroke. And as many of you say and have taught me in this particular series, children are not just survivors, they're thrivers. And I love that concept. I'm going to keep that and carry it forward. And so that thriving comes out in the outcomes. And I like to look at this as the glass more really at least or close to half full. We know that a majority of children have some degree of permanent disability, but the flip side of that coin is that a very large percentage have no permanent disability and make an excellent recovery. So I like to carry this message to every family and every child at every moment that I can. And it's one of the best parts of my job is to be able to meet that family in the emergency room, and while they're in the while they're in the midst of their crisis, to be able to look them in the eye and say with hope and with honesty, your child will have a great possibility of making a great recovery. I've seen it, I know it, and have hope. You have every reason to have hope. So what about recovery and rehabilitation? What can we do to improve recovery and rehabilitation? And this is also an area of growing research and great interest. And I think that stroke neurologists have really been preoccupied, if you will, with trying to take care of children in the acute phase. And I think more and more we are teaming up with our rehabilitation colleagues, and we're responding to the parents and children's needs, that we need to look beyond the first week because you now have a whole life to live ahead of you. So how do we move that forward? Well, there's novel rehab interventions that are coming to be used more and more. And I think children who have had their stroke around the time of birth are probably more familiar, and their families are more familiar with these kinds of therapies. They're intensive therapies that can be administered over a period of 8 to 12 weeks. And this can be helpful at various stages of a child's recovery. It doesn't have to be tied to any particular time. There's intensive training or intensive therapies that are focused on gait. There's some novel and really interesting neurostimulation technologies that are being combined, and even computer-assisted technologies and therapies that are helping children to use their mind with a computer interface to interact with their world. And it's almost a miracle to think about these kinds of things, but it, I think, is very exciting and great reason for hope. It's also a bit of a challenge because we need, as providers and as the community of families and rehabilitation professionals, to demand these and to find funding for them and to make them move forward. I also have learned over and over again that we have to extend our view of promoting recovery to the home and the school. School and home is where life happens and where rehabilitation happens. And we learn over and over again that a child needs their mind to be working as well as their body in order to make their recovery. And so again, I'm very lucky to have resources in my program where I've got a neuropsychologist and an educator, and all of my team members are aware of and understand some part of the neurocognitive profile of their child, and they incorporate that into their recommendations. And then one of the biggest lessons I've learned is how important it is to be able to communicate between the healthcare team and the school. And the family is obviously a very big part of that. So I've begun to kind of rethink how we should conceptualize rehabilitation. And I've put it this way. We have the child has sensory and motor systems, and this is where things like constraint therapy and gait training come in. They have a communication system, and this is where we need to use aphasia therapies. We need to pay attention to vision and hearing. And then, of course, they have their mind and their cognitive and behavioral profiles. So we need to incorporate all of these and have an understanding of how all of these parts work together. And we need to do this within the family. There are cultural differences. There are individual differences. We need to figure out how to make this system work within the school amongst their peers. And we need to understand how this all fits in to regional and even geopolitical factors. There are many parts of society and our political systems and our economic and governance systems that play into this picture. So what's on the horizon for this? I think we're learning more that we need to target our recovery and our repair strategies according to the age of onset and where a child is in their journey of their development. Things are different for a child who had their stroke at birth versus those who had their child as a toddler versus those who had theirs as an adolescent. We need to really think and work with biomedical engineers and computer specialists. We need to bring basic scientists into the picture to think about how we can use cellular therapies and novel drugs. We need to better predict and prevent epilepsy. And we need to leverage our knowledge and grow our knowledge of the genes and gene therapies. And there certainly could be a role for these approaches in the future. So again, I think I'm so excited to have been part of this community for 20 years now and been able to see the growth of, or the role of old friends in growing into new alliances. There is now an international pediatric stroke organization that brings together professionals of diverse backgrounds. We have launching our first in-person conference that's happening in Vienna in a week. There are organizations like the American Congress of Rehabilitation Medicine that brings together rehab professionals, and Pediatric Stroke now has a stroke task force that's a part of that organization. And these two groups, the IPSO and the ACRM, are joining forces. There are certainly many other professional organizations that have been paying more attention and devoting more resources to pediatric stroke, including the NIH and the American Heart Association. And then I'm coming back to all of you, and there is no power greater than that of a determined and loving family to advocate for the child and to imagine things in a different way than those of us who are stuck with our own way of thinking about things. And I know parents come together in very informal ways. You also work together on a local and national and even international ways. Parents can be strong voices for their child and for the cause of pediatric stroke at the level of school boards and government, even within athletic organizations and arts organizations. And there's a place for a parent voice and a child's voice, I think, in all of these, because this is where children live and how they thrive after they are recovering from their stroke. So I'm continually inspired by and amazed by all the efforts that you as parents can make to make a difference for not only your child, but for other children who might suffer the same fate. So I'll close there and just acknowledge a number of people who've made the work that I do part of a great journey and a great success, and I'll just leave it there.
Thank you so much, Dr. Ichord. I want to facilitate the question and answer session and also mention that now Patty Mussolino's on the call, so she may chime in from the neurology perspective from Mass General as well. So Flora, if you're able to come on and ask your question. If any of you are here and can ask your come on camera and ask your questions, it's the most compelling way to have our discussion.
Yeah, thank you for having me. Yeah, my question is, there are people, they have, after their stroke, they have epilepsy, right? But as I do the research, I think maybe my number is not right, but anyways, there are people have epilepsy and people don't have epilepsy after stroke. But so what is which my daughter is the one who has epilepsy after the stroke. So what is the reason why people have epilepsy after the stroke, which neurologists normally say is a scar that has in the brain? But I just want to, I guess that's the answer I'm not quite satisfied with. So that's why I asked that question again.
Well, I share your dissatisfaction, and I think that this is an area that I've been very eager to see attacked by experts in epilepsy. And I think epilepsy specialists are learning more and more about how genetics plays a role in children having epilepsy. Clearly, children who have a stroke have a good reason to have epilepsy because a part of the brain is scarred, and that area of the scar is an area where networks don't function well. But you asked exactly the kind of $60 million question, or even more than that. Why does one child with a similar injury have epilepsy and the other doesn't? And I think this is something that many people in epilepsy and in stroke neurology are very interested in learning more about. And hopefully one day, as we learn more about it, we'll learn how to prevent a child from developing epilepsy. So you asked the right question. We don't have the answers yet, but we need to work on that.
Thank you. And I think I have a second question. Should I wait until the next one?
You can ask it right now.
Actually, I forgot it. Can I come back? I forgot my second question. Yeah.
Sure. Yari, are you able to ask your question?
Hi, sure. Yeah. So my question is, my daughter had a perinatal stroke. It was dated to about 2 days before the birth or during the birth. And it was pretty extensive, very diffuse, affecting both lobes, the occipital, parietal, and lots of different areas. And the MRI looked a lot like HIE presentation, or a sort of metabolic disease, according to the neurologist. But then it ended up being a stroke. But I don't know if it's because of the trauma of that moment of the birth and what followed. But I don't remember them explaining that they did extensive testing. And she has been gaining a lot. She has been really healthy. But I don't want, that underlying, that there is a possible underlying condition that caused the stroke. Now, you responded a few minutes after I asked the question with the high risk of the birth, but I still want to know if there are other testings that I should ask for.
So I can't speak specifically to your child. I can talk in generalities that that there are a few factors related to the pregnancy itself that are associated with a higher risk of stroke, but those factors are really very nonspecific. And in most cases, it's impossible, even with extensive testing, to nail down exactly why a child had a stroke around the time of birth. We have a notion of the general process where this happens, where a clot forms in the circulation of the placenta or the baby's circulation due to any of a dozen or more different reasons why a clot might form. And then it travels from the placental circulation to the fetus, to the baby, either right before birth or around the birth process. And because of the way the heart and the circulation are made around the time of birth, that clot can just very easily travel from that part of the circulation to the brain. And even it doesn't, and these things can happen even without there being an underlying clotting disorder or an underlying abnormality in the fetus. It's just the process of coming to the end of pregnancy and the fact that circulation has to shift from maternal placental circulation to the baby circulation. And this is a very delicate balance of bleeding and clotting, where in some situations that balance just simply by pure chance tips toward the direction of a clot forming, and then that clot unfortunately making its way up to the brain. So that's the kind of general explanation that I can give. And there have been some studies that have looked at whether it's useful to do extensive blood clotting testing in the parent, in the mother or the baby after a newborn stroke. And the answer is the yield of these quite expensive tests turns out to be pretty minimal and almost never gives an answer as to why it happened. There are a few circumstances where that might be different, but in the vast majority of cases, we don't come up with an answer that has any implications for future management. And I know that's really unsatisfying. And again, there's certainly people who specialize in this area of neonatal stroke are trying to find better ways to identify in advance of a stroke occurring, which moms and babies might be at more risk. And so this research is ongoing. But as yet, we don't have the answers to be able to predict out of the millions of babies that are born every year, which ones are the ones who are going to have the strokes that we can do something to prevent it. I think the most that people usually end up saying is to optimize the health of the mother and the baby as much as possible, and to do things like no smoking and to get good prenatal care, and that I think those are the things that we know can be helpful, but at the same time, we don't have the answers that I think you probably wish we had, but we're working on it, and there's research actively being done.
Thank you so much.
And thank you, Dr. Ichord, for giving us all this time and sharing your experience, expertise. I know you've been introduced, but as someone that has looked at the work that you put in place, including the networks, the ability to train the new generations of child neurologists and other caregivers that care for the kids with pediatric stroke in international networks, it is truly an honor to hear your perspectives. I do want, Yari, one thing I want to say that I think is important is we do now know, at least from the studies that have been done thanks to these international research studies that Dr. Ichord has been the one initiating these consortiums, that the chances of having another stroke when there is not an obvious cause, which usually comes up from the workup that most babies get at birth, is very, very, very low, if not zero. If you don't have a congenital heart disease problem, we know that even with a clotting predisposition, the chances of having another stroke are very, very low. I think this is maybe important because sometimes it's why are you looking for an answer is important, but I bet part of it is my baby or my child at risk of having another event? And we know the recurrence of the stroke in these cases is close to zero if there is not a cardiac condition or a genetic disorder.
Yeah, thank you for that. That's a very good take-home point. And I also use that information in helping to reassure families, how will my child's child have a stroke? Will my next pregnancy have a stroke? And I can almost always say, no, that's not something we need to spend time worrying about.
So just in the interest of time, I'm going to try to combine some questions. So Flora asked, her second question is about fatigue in a child who had a stroke at age 2. And then Maddie came on and asked about the value of sleep in recovery. So I sort of want to have sort of Dr. Ichord's thoughts on sleep, both why a child may be more tired after brain injury, as well as an adult. Maddie's talking about his mother-in-law's recent stroke.
Yeah, this is a very common question. I think one of the things I've learned by being a tribe elder is that there are parts of neurology and neurological science that our field is just beginning to scratch the surface of. And one of those is sleep neurology. And I think many of us have learned over and over again that our patients who have brain injury of any kind have trouble with getting good, healthful, regular sleep. And then in turn, the lack of good, healthful, restorative sleep has a negative impact on their day-to-day function, but it also probably has a negative impact on their journey of recovery. So what you're reporting is absolutely true, that children have sleep problems. They often have fatigue. They often have trouble managing the demands of the day. And this is one of the things the brain does, is to regulate sleep and to get good quality sleep. And this is probably important because it's important to survival, and the optimal brain function is important to survival. And so getting good sleep is necessary for having good brain function. And so it's a very important observation. And I think sleep medicine is an area of growing research. And I hope that those of us who care for children with brain injury are able to bring into our practice lessons from sleep medicine and how we can use therapies from sleep medicine to help our children and their families, because this affects the whole family. When a child isn't sleeping, helps them to sleep. So absolutely, I have this conversation almost with every patient and every family. How is your sleep? What can we do to optimize your sleep? And these days with cell phones and iPads and everything invading the sleep space, it becomes sometimes a real challenge to try and modify behaviors that will be necessary to get the best possible sleep. So a really important question, a really important part of life to manage and to try and optimize as part of brain recovery.
Great. Maria H., do you want to come ask your question about spasticity?
Yeah, thank you. Listen, I'm really impressed with what I'm hearing today. To be honest, the amount of diagnosis and analysis that's done, I'm just so impressed with that. Hasn't been my experience personally, and I've got a very similar story to Yari there. In terms of the spasticity, there is a lot of PT, but it's kind of fighting an uphill battle when there's a lot of growth going on. Is there anything that you can maybe not recommend, but do you have any knowledge of any surgeries that would reduce that sort of thing? Or
so I appreciate that dealing with spasticity is a problem that changes with the age and the size of the child. And every time a child has a growth spurt, then you may experience a change. And it's a dynamic thing where once a joint starts to become contracted and you start to do an intervention, then you may get a temporary worsening as you try to put stretch on that muscle. And here's where having a team of experts that are really up to date on all of the different techniques that can be done to mitigate the effects of spasticity is really helpful for me. So I don't have to be the one to learn about the medications that are used for spasticity, the surgeries, the bracing. This is where having a team that works with me with these families really take over. So there's no one answer for any given patient. I think it really comes down to putting together the best team of experts possible. And the other point I'd make is something I've learned from my colleagues in rehab medicine, that sometimes it's helpful to reframe the question of what should I do into what does my child want to accomplish? What are the goals of my child's interventions? Put in terms of what does my child want to do? So the therapist or the physician might think, well, I want to reduce the spasticity in this arm. And the child's perspective might be, well, I just want to throw a baseball, or I want to operate my computer. And so what I've learned from my rehab colleagues is that sometimes it's important and necessary to reframe the question so that it incorporates the goals of the child and what they want to do in life. And what does that do? Well, number one, it I think it helps the families and the professionals to prioritize all the interventions, because you could take a child who has many different needs and you could fill their day with therapies. And it might not accomplish what that child wants to do with their time. And it may be sort of a law of diminishing returns. So what my team has taught me is, let's see what the child and the family wants to accomplish in their everyday activities and what's really valuable to them, number one. And number two, how much time and effort do they actually have to spend on a individual therapy versus how much time do they want to spend being out on the playground with their friends and learning how to get on with each other and learning how to function in a classroom. So I guess I would take the spasticity question and maybe reframe it a little bit and put it in the context of what is that child what is their day like? What is their week like? What do they want to do with their skills and adapt? And when you attach a therapy like a spasticity therapy to a particular goal that a child wants to accomplish, there can be all kinds of payout. If a child wants to do X, and in order to do X, they have to do certain exercises, and sometimes you can move the bar forward in a way that you didn't expect, because that child's own imagination and own motivation will come into play when their goals are built into the therapy program. I'm sure I'm singing to the choir here, because I'm sure as parents you've all experienced this, and you can't force a child to do an exercise if it's just work for them and it doesn't incorporate their own particular desires and goals and what they want to do.
Thanks so much. So we have several more questions, but we also need to honor Dr. Ichord's time, and she actually has clinic this afternoon. So I'm going to invite Patty to close it out, and we'll take these extra questions and use them. Possibly we can get them answered offline or somehow use them for future events. Thanks so much to everybody, and I will share a survey link in the chat. Patty, do you want to speak to close it out?
Thank you so much, everyone, for participating. Dr. Ichord, again, thank you not only for coming to share your wisdoms with us, and I think a lot of what you said is to put the kid and the family in perspective, and we're trying to catch up with the research that is needed to answer a lot of the questions that they have. But I also wanted to thank Alex and Claudia and the families that you share stories, because they also, in a way, are being part of this, and every single one of you guys that have participated. May is a Stroke Awareness Month, so we are ramping up our efforts to provide more of this educational series, and it's gonna be very much centered on reconnecting after not being able to do events in person. So we are gonna have some webinars online that are gonna mostly hinge on play and in preparation for the summer activities that you may wanna think about. And then we have an in-person for the local or semi-local people around at the end of May that we would like also you to participate. But as you can see, when we invite and collaborate and work with more people around the world that have this unique expertise, the value of what we can do together is much higher, guys. So take some time to answer the survey. The survey has questions about what would you like to hear about, but also who do you know that we should be working with to bring them here as also our speakers, and maybe start developing your own local networks. So again, thank you so much, Dr. Ichord. Thank you, Claudia. Thank you, Alex. Thank you, Mara, for all the coordination and the parent board that advises this work all throughout the last few years. And we'll see you soon. There's going to be many activities in the coming weeks.
Thank you, Patty, and everyone. And it was really an honor to be part of this. I receive as much as I get, as I give. So I appreciate these opportunities and wish we could be in person, but perhaps we will soon. And take good care of all of you and yourselves, and best wishes for you and your families and your children.
Thank you.
Claudia
Bye,
and Alex,
everybody.
great to see you. To see you soon. I have to
Great
come and
to see you,
visit
Dr. Ichord.
Yeah.